and we're getting there. There will be, by the way, one more opportunity for audience interaction if you would care to. So start thinking about your own thoughts for the end of the day discussion. But now we just go around the table. Roundtable members deliver one to... Oh, we have one from email? Oh, this is, okay, great. All right, I'll just play her in a little bit then. One or two key points that you learned through the day, and I think in fairness we'll start with Kim, because that means George gets to hear all our key thoughts and act like he's been here all day.
Thank you, and George, I hope we do you some favors by starting over here and ending with you. So thank you again to all our presenters, and I appreciate the wonderful presentations and the excellent conversation. And I'm going to go right back to where I started the day, and you'll be glad that I didn't say this after everyone spoke today, because I could have, I feel like. And that is that what this comes down to is really a partnership with our patients and our consumers. And that starts at the design of these post-discharge care and instructions, and also the importance of doing so that we eliminate the sort of check the box mentality that we have in the way some of these are being delivered, right? It's a requirement that we do this now. So I know in my own case, I see my internist and I have this fabulous conversation with her, and she never mentions this, and as I walk out the door, the receptionist hands it to me, and I'm done with it, right? And so if we want patients, if we want these to be of value to patients, we need to engage them in the design of them. We need to recognize that one size does not fit all. And I love the examples that we had of so many of the ongoing conversations where these are used as a tool, and think that is certainly examples of best practices. So again, thank you all. And as long as the consumer and the patient is kept at the center of this, and we're using human-centered design and thinking, I think that's where our best possible outcomes can come from.
So I wanted to come back to a thought that came up briefly when Michael was talking about health outcomes. And I think I've spent the last 3 years trying to figure out how do you make health literacy relevant to an organization where it wasn't necessarily always the highest priority before. And for us, it's tying it to both adherence and patient safety. In terms of health outcomes, like for the Walgreens Northwestern pilot, we're looking at A1C, we're looking at high blood pressure, we're looking at adherence metrics. So I think the more we can measure the actual impact on patient health, that doesn't hurt anything either. I also just wanted to post something, I talked about Will Schrank at CVS or Walgreens. I would love to see, representative from a patient advocacy organization, or, have we invited Epic to the table, and maybe they've said no. But, having worked in the field for the last few years, I feel like 80% of the people in the room are the same people who are in Boston in the fall. And I would love to just see the conversation expanded. And, that's the kind of thing that I've been doing in my own job, is trying to figure out how do we make this relevant where people haven't been thinking about health literacy. So I just wanted to post that. Oh, and also NCQA. NCQA actually met with back in 2011, sorry, Margaret, about health literacy. I met with Peggy O'Kane. And so they're right here in DC. And I would love to see them at the table as part of this conversation too.
No, thank you. I thought it was an absolutely awesome day. I want to thank all the speakers. It was somewhat unique in that it was a really practical day. We had some real life examples, and I think things that came up, everyone in the room in some way could relate to. So, from that point of view, I think it touched everyone in some way. But I think we have to remember that the discharge summary is really for the patient. The aim of it, more than anything, is to keep the patient as well as can be after his hospitalization and prevent them from getting back into the hospital. So from that point of view, it really needs to be, and this is the information that I gleaned from today, although there was a lot more information. I'm just going to focus on a couple of points. One, it needs to be meaningful. succinct, up-to-date, and accurate, and I think those are the primary things. It also has to take into consideration the different patients and their cultural differences. And I think the other point that I wanted to make is that we have to be mindful that it's not just a document, that we have to do education prior to discharge and we have to follow up post-discharge.
I wanted to make a couple of points. One is to make sure that we stay squarely in the after visit summary space, and that we've been talking a lot about the discharge situation. I think we've had more traction in hospitals. We have the CMS excess readmission payment incentives. We have HCAP payment incentives. Hospitals are starting to pay more attention to this. But I think we have a lot less traction in the outpatient setting, which is where a lot of the care that's delivered that keeps patients out of hospital. So to think a bit more about that. Chuck referred to a workshop that we had a number of years ago, the Can We Confuse Patients Less? Was the title of one of the presentations there. And that was about the patient-centered label on medicine container bottles. And I hearken back to that. It was one of the more memorable moments for me, with Ruth Parker standing up in front and looking around the audience, who include very many august speakers, and saying, all right, who is stepping up to the plate to make this happen? We've been listening all day as to what's wrong. We have models of what right looks like. Let's make this happen. And US Pharmacopoeia still came to the plate, and they volunteered at that workshop, and they proceeded to assemble an advisory group, a panel, to come up with standards, which they then published as a chapter of what are recommendations for a patient-centered label. And I think that we are at that point in time with this topic, that I really think that the IOM Roundtable on Health Literacy could potentially be moving this forward. And I think, Lori mentioned a number of the people who need to be part of that conversation, but getting vendors, clinician associations, patients together to try and help the market realize this opportunity, I think is something that where we could really make a contribution as a group.
I'd like to build on something that Kim mentioned in terms of always keeping in mind that the after visit summary, the discharge plan document is simply a tool and certainly cannot replace the human element. And as so eloquently shared by Rachel, the power of empathy cannot be understated. I think so often to my own experience as a healthcare provider, knowing that patients are so overwhelmed and often feel scared and alone, that the power of that human element, that empathy, even the provider remarks that Rachel shared, and I even think back to a year ago when we had Bridget McCandless speak to the power of. Remember, she spoke about the very low tech. The low-tech methods she used, and each patient had a spiral-bound notebook that they brought with them, and she would clearly outline directions. You were on this medicine, you have this, your blood pressure today was, but she always ended with a personal note, and that personal note was, keep up the great work. Looking forward to seeing you next week or in 2 weeks. That little human element, the power of that someone is with me, someone is partnering with me, can make all of the difference. And it certainly would factor into a patient's self-efficacy. Gosh, my provider believes in me, I guess maybe I can do this. And also the power of also speaking to self-efficacy, the power of formatting speaks to the overwhelming feeling, that information overload, and taking from what we know about learning science and the use of appropriate formatting, even the idea of cognitive overload. When you're feeling pretty good, there's that element of cognitive overload. So it's so important for us to understand that first impressions make a big difference as well. So if you're given a very thick booklet or a very comprehensive discharge summary, the idea that it's too much, I'll never be able to deal with this, also plays into that sort of self-efficacy part. So that human element is something I'm really interested in and quite passionate about. And I think we heard a lot about that today.
So my comments are kind of a combination of all that have been said before me, but I think if we continue to look at it from the patient's lens, that's most important. And it brings to mind a conversation I just had, I guess 2 weeks ago, about the patient portal. And it was a little surprising to me that many of the physicians in the room when we were having this discussion did not want to upload certain information into the portal because they wanted to talk to the patient. And, so then somebody in the room said, well, what if the result comes back on a Friday in the afternoon and I'm anxious about it, and now you're, not looking at that, so I'm going to have to wait till Monday midday. That's my information. I think sometimes we lose sight. It's about the patient, and it's their information. It's their document. There's a process that goes along with that. We need to continue with the partnerships, and it's a lot of P's, but partnerships, I think pilot projects are really important. We have to look at the low-hanging fruit, where we can get the most bang for the buck, and continue to build upon that.
I'm Betsy Humphrey from the National Library of Medicine. I'm the person that spoke all day and never said who she was. I thought I'd say it at the end. I guess this has been a very fascinating day, and it is very interesting to hear from all the speakers and see the good examples and hear the bad example stories. I guess in the end, I feel like it just proves what we already knew, that there is nothing in the healthcare process that cannot be improved by making a real attempt to figure out what the patient wants to know, and then giving them that information in a way that they can understand. I think there probably are system ways to improve that. I guess that's all I'll say.
So thanks to everybody in the audience who sat with us all day and contributed, and also the Roundtable members. It is pretty exciting. I feel like we just keep learning and sort of adapting our understanding to do a better job around health literacy. I think the take-homes for me, again, sort of mimicking a lot of what we've just heard, so it feels like we're moving on a similar wavelength, is really what's our role in creating human-centric organizations with those attributes as our framework, our guardrails, and how does health literacy fit into that? So in terms of after visit summaries, how do we play a role in creating a visit about which we then summarize? And what's a visit look like? And then where does health literacy fit? And I think we heard a lot about that and thought a lot about that today. And then I like the bird and the stone and throwing stones at the bird. Not my preference, but it's a good model to think about that we want to avoid. And then I think too, again, in discharge planning and after visit summaries, I noticed in my work that some of our two biggest areas of work for me are really understanding what humans need and want, and learning to listen ourselves, and where health literacy, and then how to create health systems that help people navigate. And I know that's a health literacy piece in the crossing the quality chasm, and that we have yet to really, in this group, I think we'll continue to think about health literacy and navigation and where that fits. So, thanks.
Rob Logan, National Library of Medicine. The day reminded me of the importance of after visits and discharge information communication. And also I was reminded of the importance of comprehensive data integration in assessing a patient's condition. I approach health literacy from a non-clinical perspective, so insights that underscore the latter issues enhance my understanding. They're helpful to me. I like the comment in the morning that discharge information and health education are a shared responsibility that certainly involves primarily physicians, but it certainly also includes nurses, community health workers, and health coaches. I also appreciated the comment in the afternoon that caregivers and families sometimes are key health educators as well. And discharge planning information communication should be evaluated with all information sources in mind. I enjoyed the introduction of a few best practices. I would have liked to have heard more, certainly about others. I would like to know more about where the exemplars are. I thought the inclusion of the importance of hospital admission information and linking discharge with admission information was one of the more insightful points I heard all day. The point was consistent with one of the presentations that suggested a key piece of information for many patients is what is new or different today in my condition than it was before. And that leads to the next question, what do I do about it now? I certainly suggest the roundtable gather more admission and discharge communication practices for a possible subsequent publication about this issue if that's what the roundtable has in mind. Also, an apology. I've been getting emails all day that I have damage in my residence, and with apologies to everybody, I'd really like to go make sure everything's okay. So I'm going to depart, but I'll see you tomorrow morning. Thank you.
So this was my first meeting here, and I must say I'm really impressed with the level of conversation around the table, really am, and the transparency of the discussions. It made it very easy to really get a leaping start. But if I think about it, I do feel the importance of the need for continuing learning around the issues we discussed. And I think that's been mentioned a couple of times, particularly around the area of discharge instructions, but they're really not discharge instructions. They're instructions that begin on day one. And especially with Mark Williams' comments related to hospitalists and the recognition that we have a change in the delivery system, which really changes how we think about the whole concepts of not only hospital admissions, but the ambulatory side in addition. So if we're thinking about this as a learning process, as we teach the team of healthcare providers, and we all agree that it is a team function, it's not a function that's exhibited by a single individual, and patients, since they're part of the equation, regarding AVS and discharge summaries around the issues of health literacy, I would like to look, and I think I mentioned this earlier, as to what the drivers are here, and emphasize once again the idea of a framework of both the National Quality Strategy, which lists goals and priorities, and the IOM concept of a learning health system. I think if we can put that together in terms of this being really the National Quality Strategy, meaning patient safety, family and patient-centered care, which is what we're talking about, care coordination, decreasing the leading causes of mortality, and puts this into a framework of a learning health system, I think we've accomplished a lot of what we have said around the table.
I still think you should go. But anyway, so Andrew Pleasant, Canyon Ranch Institute, thank you all for participating. It's been lovely. We'll come back to that. In terms of today, I noticed that in the morning there was a very real concern expressed about the balance between the regulation of these documents and the information therein and the usability of them. But when the conversation shifted to learn what the patient wants first, that concern went away and absolutely disappeared through the rest of the afternoon, which I think is in fact a process that could become a best practice and be regulated and get around that concern that people expressed in the morning. I would just say even the best document or process, if it's in a misaligned system, will be limited in its effectiveness. So to just focus on the document or to just focus on the process without also focusing on the larger system and the culture that supports that system would be an incomplete solution. Now, whether you start with the document and then work up towards changing culture, or start with culture and work down towards changing the document is probably best decided on a system by system basis. You know where you work and you know where your leverage is. But I love the point about if you don't have the power, I think it was Michael, if you don't have the power to reinforce this, find someone who does. Champions are clearly going to be really important in this change. And I hope, Cindy, that you're right, that we are, but I still think there's a little bit more work required. One thing I didn't hear a lot of, even though it was a very practical day, was the role of theory in informing the design of these products. And practical is great, but there is a true role for theory so that you know why you're doing what you're doing. Then you test it and see if it actually works, and you modify the theory or you modify the project. It's called the scientific process. It works out pretty well sometimes, I've heard. Sorry. So in that, right, just be very careful of being too reductionist and looking at one small part of that. Integrative is the challenge here, it's clear. Integrating communication, integrating players on the team, especially in a fragmented system, and that needs to be figured out. So I don't think we heard a solution to that at all throughout the day. And now I'm going to be Susan Paisano. I was channeling George earlier. I'm trying to change my persona here. So for those of you who don't know, Susan is at AHIP and an IOM Roundtable member. And she just briefly notes that I've been struck by how discharge planning is described as something separate rather than something that is, and I keep reading should be, but she said is integrated into the entire hospitalization as discharge preparation, as she notes, Rima suggested earlier. So that's Susan's comment.
Pat McGarry, American Academy of Family Physicians. As always, the discussion today was very thought-provoking and raised a lot more questions maybe than answers, I think is indicated by best practices. One of the things I like, the shift in semantics of discharge instructions. There's such a sense of finality to that discharge. I mean, you're done. And no, you're just starting. You're on the road to recovery. So it's very important I like that after visit summary is much more patient focused and centered. And so I appreciate that distinction. I'm also a little concerned though about seeing this plethora of discharge instructions that were redacted. And I'm thinking about this information that's there and a patient leaving the hospital in a wheelchair, groggy, disoriented, and they have a pile of papers in their lap. And, who's seeing those and how are they being protected? Which brings me to the other point that I'm concerned about is we really didn't address HIPAA issues in transmission of electronic data regarding health records. So I think we need to think about that. I'm also, I echo the concerns of my colleagues that the patient involvement and patient engagement in a panel form that actually evaluates after visit summaries, that they really are reflective of what the patient needs is a crucial component. Because I tell you what, if people don't understand what's in those documents, they're going to go to Google. And that's where they're going to get probably a lot of their information, which may or may not be accurate. And then finally, I am really kind of shocked, and I do know that this happens, that many of our family doctors do not receive, or generally are not aware of the after visit summary if they didn't even know the patient was in the hospital. So there's a breakdown in the system. I think that this coordinated care model that we keep on talking about really needs to be kind of more articulated clearly and understood by all members of the healthcare team. So thank you for a wonderful day again.
I certainly second that about a wonderful day. I feel like I've learned a lot. It was just very exciting. I also feel as though I bore witness to a true shift where we're turning a corner. We're moving away from a myopic focus on the patient's capability of accessing information. And instead, we're focusing on our creation of accessible information. So now, finally, we're in that issue of looking at a dialogue, and I celebrate that. My take-home point has to do with scientific rigor, and I want to build to some extent on what Andrew said as well. We're too accepting of shortcuts when relates to information exchange. We have to insist on scientific rigor. This has been well documented, formative research, not only the need for it, and the value of it, but the processes and methods of how to do this. We cannot let our colleagues, we cannot let ourselves, we cannot accept the argument, oh, it costs too much, it's too time consuming. We don't accept that in any other aspect of our medical and public health science. So we should really move ahead and insist on greater rigor. And part of this scientific rigor is that we build on knowledge that is accumulated. So unless we apply findings, we are not engaged in science. We have very strong findings, theory, and practices in health education and health promotion that has to do with the active engagement of participants and the intended audience. Proof that shows that programs are enhanced through active participation and the voice, incorporating the voice of the participant. So we have those study findings, we have to incorporate them, building on participatory work. There's also medical sociology and medical anthropology that has long talked about the shift from acute care where the passive patient is worked upon to what happened when we started entering the era of chronic disease management, and the patient and the physician, the patient and the public health practitioner have to partner together to make progress and to make change. So that emphasis on partnership is certainly long there in theory. It's long there in practice. It's long there in articulated methods. And I think that that's my strongest take home. And so as a result of that, I come away in stronger support of regulations than I ever had before. Not regulations on the content of what goes into the after-visit protocol, but on the process of how these are developed. And so that was my strongest takeaway. Sorry, I didn't introduce myself. I'm Rima Rudd, Harvard School of Public Health.
Hi, I'm Steve Rush, and I'm with United Health Group, and I'd like to thank all the presenters today for really exciting and insightful presentations. I'd also like to thank the planners and the staff for all the hard work that they've done. There's a couple of things that I took away from today, and one of the things that I heard was it's really nice to see the redesign of some of the information. I had the privilege of listening to a presentation where they said that within the first 50 milliseconds, people will make a decision on whether they're going to engage with a document or a website. Wow. And if you think about some of what we saw, that's a very disengager for me. A couple of points. Number one, I think if we're going to be asking people to use websites and portals and smartphones, et cetera, we need to be able to train them to be able to do those kinds of things. We have a lot of apps that people aren't using anymore because they really don't know how to use them. It's too complicated. The cognitive workload is way too high. I like the concept of providing the form or the app is not enough. There's all kinds of research out there that says unless there's a personal touch, maybe 2 weeks will be a period of time when people will use that particular information. And I really do think that people who are providing information do need to be trained in how to provide information in a meaningful way. I had an unfortunate opportunity within the past week or so to have a family member in the hospital, and I'm sitting there and I'm shaking my head to myself and I'm saying, no teach back, not looking at my family member, not speaking way too quickly, and I'm going, oh, God. But I think it's really, really important for us to, as I think one of the presenters said, to train the people to do the training and monitor that. One of the things that we found very helpful was when we give people forms or letters or information, there's a little thing on the bottom that says, keep this in your files. You may need it in the future. And people are taking that. I do like the concept of after hospital care plan. That's a mind shift. But all in all, I found this to be a really great day, and thank you all so much.
Wilma Alvarado Little, UAlbany SUNY Roundtable member. Geez Louise, where do you start? All right, so I'm going to paraphrase some of what Michael said from BU. I'm not going to use the other reference I was attached to him earlier. That you care about your patients when they're there, but you also care about them when they leave you. And also you want them to succeed when they go home. And I thought this really, for me, captured a lot of what was discussed today. I think that this is going to be a multi-pronged approach. We do want our patients to be successful. They want to be successful. And sometimes what happens is because of overwhelm, or how Patrick described some of our patients are discharged, everybody wants to be compliant, and we want our patients to be compliant, but there's the disconnect between the policy and the practice. Sometimes there's a connect, but as we found today, sometimes that really isn't happening. And so I was pleased to hear the perspectives from oral health. Alice, thank you for the visual. The issues of physical health and also behavioral health. I'm very appreciative of the strengths perspective that has been utilized. I think that we should draw from that and also continue to keep that magic wand in mind, or as we say in social welfare, the miracle question. Thank you.
Bernard Dreyer, I'm at NYU, and I'm representing, I guess, pediatrics, the American Academy of Pediatrics. So I've made a list at the beginning of this of all the major points, all of which have been covered, but I think I'm going to focus on a couple of overarching issues. And so I have to agree with Cindy. Yes, right. Yeah, everybody else will come around. But I do think it is important to think of how to move this to action, because I do feel that the train is leaving the station on this issue. All of the EMRs and all the hospitals are well into this. It's going to be much harder to get them to change once it's established. And so I do feel this fierce urgency of now that we do need to, this is the time to intervene, to do an intervention, rather than to wait until it gets solidified. So I would urge us to think about how we can do that and maybe have a serious discussion. And I know there's always the tension between between wanting to learn more and wanting to study this more, because we don't know everything. But guess what? I think we know a lot. And I think what we could take what we know and start using it. And so that would be I would support Cindy's call to action. The last comment I want to make is about the overwhelmed healthcare providers and healthcare systems. As we've heard that theme to some degree, we're giving people more and more and more to do. It's taking away from their ability to actually really interact with a patient, and also health systems are under a huge burden. All of these new regulations are really taxing them. I mean, I'm on the medical board. I was the medical board president of my hospital. I can tell you that, and I'm in 2 health systems, and they're both reeling with where do we focus our energies? So I guess the question in that is, number one, how do we get their attention about something like this? But number 2 is, how do we think about this so it's not an additional burden? And it's not viewed as one more unfunded mandate that they're given to do, which, to be honest, is never going to be the major unfunded mandate unless it costs them hundreds of millions of dollars.
Yeah, thank you. Really appreciate this opportunity to sit here and be a participant and listen carefully rather than manage the meeting. So first of all, I want to thank Andrew for stepping in and doing, at least from what I've seen, an excellent job today. I'm just so pleased to see Bernie Rossoff here. And as one comment that I've heard so far indicates, how important he'll be in these conversations going forward. And I'm impressed with the last panel and the comments I've seen so far. So sitting here thinking a little bit, I'm struck, and maybe this, and since I only saw the last panel because I was traveling the rest of the day, maybe this has occurred to the rest of you earlier in the day, but I'm so struck by how the after-visit summary is only a fragment of what the patient needs to achieve in order to achieve good health. But it's an important fragment. It's an important transition from something to something else. But I can't get away from that thought that the after-visit summary is part of something larger, or ought to be part of something larger in terms of what we're trying to do to help the patient get information, access services, and so forth. So what is it for is the question I have. What is it really for? It's obviously to convey information in making a transition from hospitals or from visits where new insights are gained or tests are obtained or an illness has been recovered from in an institutional setting. But beyond that, what is it for? And I especially with this last panel, next question came to my mind is, what's the patient's self-management system with which the after-visit summary is intended to interact? And I'm so struck by the examples in our book, which I've already mentioned once, about how complex the medication lists are and so forth. And so in that hospital kind of setting, we could focus on medications and treatments and changes. But basically, the patient is concerned also about how to stay well and what they need to do long-term to be well, in addition, as well as how to manage their chronic disease in a longer term. So at least the after-visit summary interacts with that. And so I'm left with the question of what the health literate patient self-management system looks like that this after-visit summary interacts with. What's their everyday method for managing their medications, for their behaviors, their diet, and so forth. And then thinking about that a little bit, was thinking about the concept that we have, and so some of you know who have been around me on this roundtable over time, I come from quality improvement and systems thinking in terms of quality overall. And so I've been thinking about the concept of patients up to date, or individuals up to date, which we use in quality measurement. So if you're a man, you have a certain set of services, preventive services that you need. And if you're a woman, it's different. If you have a chronic disease, you have management things that you need to do. But you get a good score only if all the appropriate things by gender, age, and condition are met. And it seems to me that ought to be expanded to all the appropriate things by gender, age, condition, and health literacy, numeracy, and cultural status. And we ought to be thinking about that concept, that background concept. And I wonder if we shouldn't be asking the question of what that system ought to look like for people, and against which these episodes of hospitalization and so forth occur, which generate the need for after-visit summaries that interact with apparently something. But it's not a static sort of problem for the patient. It's a dynamic one over time. And then, so I'm thinking about that. I went to the web here just a minute ago to look at the definition of health literacy, the one that we have from our report that's now almost 10 years old. The degree to which individuals have the capacity to obtain, process, understand basic information and services needed to make appropriate decisions regarding health. And it seems to me that needs updating. It's not just decisions.
I did not say that.
But it's behaviors. It's got to be behaviors and actions. I mean, it's got to be something beyond decisions. It's not just information and services, but it's also skills and a lot of other things that are not mentioned in that definition. And then it's not just for the purpose of making decisions. It's for the purpose of doing a lot more. And so I'm left with that. Also struck by Bernard's comment about being overwhelmed. Well, yeah, that's a sign that our health systems need to approach the patient differently. in the modern age. You cannot do it the same old way with the same old technology and the same old professional skills in the complex modern world and not feel overwhelmed. That means the way we're going about it is wrong, not that we need to dumb down the approach. So I agree with your comment. Systems are overwhelmed, and they are doing that, but there needs to be a change in terms of how they approach that. And I think by thinking about those systems, taking advantage of technology, figuring out how we can be smarter about helping the patient is the answer. Anyway, thanks.
Well, if we get closing comments like that, maybe I should moderate more often. I'm just going to say. Yeah, I know, but I can take credit for something. So we do have just a few minutes. If someone from the audience wanted to make a quick comment or question, and it's been a long day, though, so I understand if you don't. I just wanted to say that you can. So great. Well, let me just say, now that I've done this once, and probably once, that it's the staff that makes these things work. So please join me in thanking them. And thank yourselves, and that's it. We are done. Have a good evening. Thank you for coming.